later. So let me get that going. I wanted to share a quick story of why I started Uva. It actually came through a personal struggle of my own. I had a very difficult time conceiving my son, and we had expected the journey to be difficult, mostly because I've had irregular cycles my whole life. But my husband and I decided that we wanted to try to pursue parenthood naturally, and if it didn't happen that way, we did not want to go down the invasive route, mostly because I just didn't think I could deal with the loss of a failed cycle or a potential miscarriage. So that being said, we started doing everything right. I started peeing on sticks every morning, took my body temperature, 4:30 a.m. every day, used every fertility tracking app, and luckily after 18 months, I conceived my son. But those 18 months were the most devastating of my life. And the worst part was I didn't really learn anything about my cycle. All I found out was that I had irregular cycles, and I knew that going into my journey. I also realized that all the tools that I was using were basically hardwired for a woman who had a perfect 28 to 32 day cycle, and that just wasn't me. So the more I thought about my journey, I was like, the piece of data that was missing from my set was really understanding what my hormones were doing. And if I had that information, I would know exactly where I was in my cycle, and I know what to do and when to do it. And that's where the idea for Uva was born. So I'm really excited to have Dr. Lucky here with us. But because this is National Infertility Awareness Week, if all of you are not aware of that, this is a great opportunity for us to just raise awareness to how common infertility is and how many people it actually impacts. Uva is offering a 20% discount to all of our customers this month. You can use the code NIAW20 to get 20% off of your purchase. I believe we'll be dropping in the discount code in the chat box, so you'll have that for later. But love to welcome Dr. Lucky. Just a quick intro on her. Dr. Lucky Sekhon is a reproductive endocrinologist and infertility specialist, a board-certified obstetrician and gynecologist, and assistant clinical professor in the Mount Sinai Health System. Dr. Lucky has particular expertise in fertility preservation, LGBTQ family building, and in vitro fertilization. She grew up in Toronto, Canada, and moved to New York City in 2011 to complete her OBGYN residency and fellowship training at Mount Sinai. While Dr. Sekhon maintains a busy clinical practice, she continues to publish and present cutting-edge clinical research in the field of reproductive medicine. She's passionate about educating women about their reproductive health and family building options. Today, she'll be leading our discussion on reproductive health and hormones. We're going to be doing a deep dive into the role of hormones in establishing a healthy pregnancy, different ovulation tracking methods, hormones and fertility treatments, and more. So Dr. Lucky, I'd love to just kind of pass the baton to you and let you take control of this conversation.
Well, thank you so much for having me, Amy, and thank you all for spending your Tuesday evening with us, learning more about your reproductive hormones and how Uva could help you in tracking your cycle. I am really passionate about this topic because, like Amy, many of my patients who come to me express the same exact frustration. A lot of times, they're kind of following the steps that they're told by their friends or that they've read online, and they're just kind of going through the motions. But I think that there's a huge difference when you're trying to conceive and you actually understand what's happening as you're going through the process and trying to pinpoint your fertile window to truly understand your own biology. I think gives you a sense of control and eliminates a lot of the anxiety and the fear and stress, thinking that you might be doing it wrong or just feeling, fear of the unknown. And I think that it helps you to feel a lot more secure about it, even if that particular cycle you're in doesn't yield a successful outcome. You're going to feel more control and know what to do moving forward. So I'm really honored to be part of this panel and to be sitting with you all today, giving some just basic education about what it takes to establish a healthy pregnancy, and why timing is important, and why tracking your cycle accurately is really important to your success. I also want to talk about different ways that you can track ovulation, whether you're doing it at home on your own or you're coming in to see an OBGYN or your fertility doctor, and why it can be really important to check these specific types of hormones during different types of fertility treatments if you're undergoing fertility treatment as part of your journey. So let's start with a basic biology 101 of what ovulation is and why it's important. So in order to talk about that, you kind of have to zoom out and think about the larger fundamental question of what it takes to establish a pregnancy. And this might seem really obvious, but I promise you it's going to get a little bit more complicated. So there are 4 major components, right? You need an egg, you need sperm, and you need a place for the egg and the sperm to meet. So that involves 2 things, the reproductive tract, the uterus, and the fallopian tubes, right? So if we follow the journey of the egg, you have your ovaries on either side of the reproductive tract. And I'm sure that most of you are aware of this fact because society loves to remind us of it, but we as women are born with all of the eggs we're ever going to have, right? And we can't make new eggs, and we can't fix our eggs or modify them in any way. So since you were a fetus at 20 weeks, that's when you had your peak number. You know, you were in your mother's womb, you had your peak number of eggs, and you're just losing those eggs over time. There's actually quite a sharp loss rate from 20 weeks till the time you're born. And then thankfully, it's just very gradual, and you're born with like 1 to 2 million eggs, right? And by the time you get into menopause in your 50s, you have less than 1,000. So we know that we're always losing eggs over time. And what's interesting is that in any given cycle, you're not able to have access to all of them. So they're kind of stored in this repository, your ovaries. And every month, a certain number at random get pulled, or I shouldn't say every month, every cycle, a certain number get pulled to the surface of the ovary where they're available, and they can actually respond to signals coming from your brain, right? So your brain controls all of this. It has this master gland called the pituitary, and your pituitary gland sends out signals called follicle stimulating hormone, luteinizing hormone, FSH or LH. And these signals are sent to the ovaries, which I'm going to just say are down here. And the first egg to receive that signal at random is basically selected. So there's a certain number that are recruited, and it's not all of the eggs that you have, the millions, right, that you're born with, but it's a smaller subset. And we don't know why those are the ones that get chosen in a given cycle. And one of them gets to be the lucky winner that ovulates. And follicle stimulating hormone, one of those signals from your brain, is what's causing the selection of that egg. We say follicle and egg, we use those terms interchangeably. A follicle is basically a fluid-filled space or a pool, and it has one egg floating inside each one. So that's what I mean when I say follicle or egg. And basically, follicle stimulating hormone makes that fluid-filled space expand. And all the while, the egg inside of it is maturing and developing and getting to a stage of development that is required for it to be reproductively competent. It is required for it to be capable of being fertilized by sperm successfully. And so, you know, there's like this competition, they're vying for who's going to get to ovulate. And the one that gets selected isn't necessarily the best one. It's more like a lottery. It's almost like whoever, you know, receives the signal first. And it gets bigger and bigger and bigger. And that follicle has cells that line it. And it actually, as it gets larger, those cells start producing estrogen, and it becomes an estrogen factory, and it's churning out a bunch of estrogen, and those levels start to rise, right? Estrogen is why you start to have symptoms near ovulation, like more discharge, and it's usually clear and watery. That's because of estrogen. What's happening inside of your body because of that estrogen? Well, the lining of your uterus, which at the beginning of your cycle is thin because you just had a period, it starts to thicken up and becomes this really lush carpet, right? And it's making a nice environment for hopefully an embryo to implant. And as that follicle is getting bigger and bigger, that dominant one that got selected by the follicle stimulating hormone, it starts to secrete enough estrogen that estrogen signal goes back to your brain and tells your brain, okay, it's time to send out the other signal, the ovulation one. And LH, luteinizing hormone, then gets sent out. And that is the final signal that tells this bubble of fluid, this follicle, to rupture and release an egg. Now that leftover follicle, which is now what we call a corpus luteum, it converts from being an estrogen factory to an estrogen and progesterone factory. Now the egg is in the tube, right? So if this is the uterus and you have fallopian tubes coming off of it, and these are your ovaries. Now that egg is entering the tube and it's sitting there waiting for sperm to fertilize it, right? And what's happening in the ovary is that leftover follicle is now pumping out estrogen, progesterone. What is the progesterone there for? Well, it basically converts your lining, that carpet, the lining of the uterus, to a different environment. It is a really important hormone that opens up this window of implantation. The lining of the uterus, it thickens, it changes over time. It's really dynamic, but it needs a certain duration of exposure to progesterone before it can be receiving an embryo or receptive to an embryo. And usually, you want there's a very finite window, and you want about 5 to 6 days of progesterone in the lining or affecting the lining prior to an embryo implanting. So the timing of ovulation is really important because of that, but also mainly because when your ovary releases that egg, the egg is a single fragile cell. And it's only going to survive for about 12 to 24 hours. And if it's not fertilized in that time frame, it disintegrates. And that seems really unfair and very inefficient, right? Because that means you have this 2-day window, roughly. It's not the same for every single person, but broadly speaking, it's like a 2-day window every month or every cycle. And for some women who have a really long or irregular cycle, that makes it even harder, because how do you predict when that's going to happen, right? We know that sperm, which is coming from this direction, if this is the uterus, right? It's swimming through the reproductive tract and getting into the fallopian tube. It is better to have sex and have that process happen even prior to ovulation, right? Because we know that sperm can withstand harsh environments and can stick around in the reproductive tract waiting for 3 to 5 days, right? That's kind of their time limit. So it's better to have sex 1 to 2 days prior to ovulation, because the sperm will sit there waiting, and it's better for them to be waiting to receive the egg, because the egg has a very short timeline and window of opportunity. So being able to track your ovulation is extremely important, because you have to be able to anticipate when you're going to ovulate in order to make your attempt high yield and improve the efficiency of a process that's really inefficient. Why is it inefficient? Why do I keep saying that? Well, every month when you ovulate one egg, it has about a 15% chance. And this isn't taking into account other factors, right? Someone may have problems with their fallopian tubes, their uterus, they may have egg quality issues, there might be a sperm quality issue. But for all comers, we generally say there's about a 15% chance of a pregnancy being produced from a single ovulation. And that's because we're expecting all of these independent events to line up perfectly, which we know is not the most common thing to happen. First, we just talked about the timing and why that's so critical. But even after the timing, not every egg is destined to be fertilized successfully. Even with IVF, when we try to force that interaction to take place, it's like 70 to 80% of the time an egg will be fertilized, right? And not every fertilized egg turns into an embryo a week later. Might be 2/3 of the time, who knows? And not every embryo will be healthy and genetically normal. We know that that is a problem that's associated with age, but no one is immune. No one is going to have all perfect eggs, all perfect sperm that turn into perfect embryos. And that's why, it's not that easy to get pregnant. And even when you have a normal embryo, it's not always guaranteed to find the right part of the lining to implant. And I don't say this to be negative or to make people feel like, oh my gosh, this is never going to happen for me. This is an uphill battle. I actually want you to feel not alone. And I want to normalize that it's not normal to get pregnant right away when you start trying. There's a lot of troubleshooting, but you want to put your best foot forward. And part of that is really understanding your ovulation, why the timing is important, and why you're tracking the hormones that you are tracking. I think that the first step is really getting the timing right. And then the rest is a lot of things that aren't in our control. But I think that it's just important to understand why we talk about estrogen, why progesterone is so important. It's also an important thing to understand why the ovary works the way it does, right? So continuing on the journey that we were talking about, if the egg and the sperm do meet in the fallopian tube, do turn into a pregnancy that eventually makes its way 3 days later to the uterine cavity. And if everything goes well, it finds a nice smooth part of the lining to implant into. Then that pregnancy starts to secrete the pregnancy hormone. When you pee on a stick, a pregnancy test at home, what that urine test is picking up is a hormone called beta HCG, or human chorionic gonadotropin. Beta HCG is the pregnancy hormone. That pregnancy and then its eventual placenta is going to be churning out that hormone for the duration of your pregnancy. And those levels are really important in early pregnancy in order to track whether this looks like a healthy pregnancy and that it's progressing in the right way. The purpose of that hormone is actually really cool when you think about it. It's a signal that the embryo is sending back to your ovary, back to that ruptured follicle. And it's telling it, hey, I'm a pregnancy. I need you to support me. Can you please keep making progesterone? And so that ruptured follicle will keep sending out more estrogen and progesterone to keep supporting that pregnancy. And it does that throughout most of the first trimester. And eventually, as the placenta of the pregnancy starts to develop and take over, it says, okay, ovaries, you can take a back seat. I'm now making the estrogen and the progesterone to support this pregnancy. And that shift happens at around 7 to 10 weeks. And that's why women who are doing IVF treatments, especially where they're having a frozen embryo transferred and they didn't actually ovulate recently, your doctors are going to tell you to take estrogen and progesterone because your ovaries aren't making that. There isn't that machinery from a recent ovulation to support the early pregnancy. And eventually they will wean you off of those drugs between 7 to 10 weeks because the placenta should be healthy and developed at that point and will be able to support the pregnancy, and you can fly solo without our help. So that's really what goes into the hormonal side of establishing a healthy pregnancy. So when we do cycle tracking, right, there are different ways to track your ovulation to help you hone in on the right timing to time your attempt and give you the best chance of success. When we do it in the clinic setting, which obviously is more labor intensive for you to come into the doctor's office, but one of the really precise ways that we do it is we check your blood, right? And we can measure, okay, what's happening with follicle stimulating hormone, luteinizing hormone, and more importantly, what's happening with your estrogen levels and your progesterone levels coming from the ovary. So at the beginning of the cycle, if we're tracking to that degree, on day 2 or day 3 of your period, all those levels should be baseline. If we're bringing you in mid-cycle, because we know that your cycles tend to be regular and we can anticipate, hey, you're probably going to ovulate around this mid-cycle point, we'll bring you in a few days before that and we can do blood work again and we can look at your estrogen levels to confirm they're actually high, that you have a follicle that's producing those high levels. And we can check your progesterone levels to make sure that that's low because that tells us you haven't ovulated yet. We can also check the LH level coming from your pituitary, which is the signal that's telling you to release an egg. And that, if we see that in the blood work as being elevated, we can say, okay, it looks like you're going to ovulate. We can also combine this with measurements of the follicle because we know that as they approach almost 2 centimeters or so, they start out at 10 millimeters. But once you get to like 20 millimeters, 18, 20 millimeters, you know that that follicle is going to ovulate an egg soon. So that's how we do it with a really hands-on approach where we're monitoring someone really closely. But for everyone in the population who's trying to get pregnant, that's not a feasible approach to have everyone go to their doctor to do this. So that's where predictor kits come into play, right? And the traditional ovulation predictor kit usually is just measuring the LH level. And that can be tricky because your pituitary gland, when it releases luteinizing hormone, that signal to tell your ovary to ovulate, it does it in a pulsatile fashion, right? And that's kind of hard to picture for people that aren't familiar with how hormones in the body work, but a lot of hormones work like that, especially coming from the brain. And so if you're just peeing on a stick, an ovulation predictor kit that's really simple, and it's measuring your LH levels, and you're only doing it once a day, and it's not positive, it's possible that you could be missing it, right? So for patients who say, I'm not sure what's going on, I haven't been able to pick it up, I tell them maybe increase the frequency with which you're monitoring it. But the other option is that you can use tools that aren't just looking at that one level. You could also use tools that are looking at the rise in the estrogen level, because that's a sign that the LH surge is going to come soon. You can also look at tools which are going to tell you, okay, your progesterone levels are up as well, because that's also nice to know after the fact. It's a sanity check. It confirms you did actually ovulate, right? And it's always nice to know in the clinic. Sometimes I bring patients in a week after ovulation because I want to check their progesterone levels and make sure that they're high enough. It's really not clear what that level should be for each person, but you take into account their history and the situation. And also you can err on the side of caution, right? Like I generally speaking, like to see progesterone levels of 10 nanograms per milliliter or greater in early pregnancy when someone has conceived naturally. But a level of greater than 3 nanograms per milliliter a week after ovulation really confirms that you did ovulate. The progesterone can't be coming from anywhere else, right? So those are the common hormones that we track. And that's kind of the reasoning behind why we track them. Amy, is there anything I left out or that you think I could make more clear about that?
No, I think that's pretty clear. There's a lot of questions that we had submitted earlier that they will help pull out some more details that we can go into in a little bit. Was there anything else that you wanted to cover overall?
Yeah, I think that it would be just important to explain what we track during different treatment cycles. So the two major treatments that we offer as fertility doctors is a more laid back approach that's kind of harnessing your natural machinery and just trying to improve your chances in very subtle ways, IUI or inseminations. And a lot of times we'll give medication that may give your body the chance to release more than one egg, just to up your chances or odds, right? And then there's the other treatment approach of IVF, which is much more controlled. You take injectable medications of actually the hormones that your pituitary gland normally send out, and we give them at a higher level in an attempt to get as many eggs to grow as possible, not just one or two, right? And at the end of the day, our goal is to grow as many of them as possible so we can extract eggs from the ovary, fertilize them outside of your body, create embryos. And it tends to be a much more aggressive and efficient approach. So we're not going to get into why we prescribe certain treatments over others for specific types of fertility issues today. That's beyond the scope of today's discussion. But a lot of patients sometimes are confused about what should be tracked or why it's being tested. And since we're talking about reproductive hormones and testing them and tracking them, I thought it would be helpful to add that to our discussion. So for inseminations where we're just harnessing the power of your natural ovulation, or we're giving you medication that could potentially help you ovulate more than one egg, or we're giving you medication that's going to help you ovulate more regularly if you have an irregular cycle. Whatever the case is, you don't have to track all of your hormones throughout that process, but it could be helpful, especially to avoid missing the window of opportunity. So I have some patients who, alongside me tracking everything, they may call me and say, hey, I actually just, I was feeling these symptoms and I was concerned because I'm scheduled to come in for my mid-cycle ultrasound 3 days from now, but I started feeling ovulation-like symptoms, and I did an ovulation predictor kit at home, and it showed that my LH surge is actually happening now. So we'll bring them in sooner because we aren't always going to be able to 100% predict the timing, and sometimes unexpected things happen. So it can be used in a way to kind of just make sure that we're not going to miss that window. And it's certainly nice for patients. A lot of patients will be worried that, maybe they didn't actually ovulate from the medication. And so that can be nice to check your progesterone levels after the fact to make sure that they're present. In certain circumstances, it might be helpful to give progesterone supplementation to patients who are concerned about not making enough progesterone. And so that can be a helpful thing to track with blood work, or even at-home testing after the fact. With IVF, the reason why we're checking estrogen levels and progesterone levels throughout those monitoring visits during the 8 to 10 days of injections where we're stimulating your eggs is because we want to make sure you're responding to the treatment, right? And when we're giving you these injectable medications that mimic those hormone signals from the brain, we want to make sure the estrogen levels are rising. That's usually the first sign that you're responding to the IVF medication. And we also, before the egg retrieval, want to make sure the progesterone levels stay low, because part of IVF is not just stimulating the ovaries, but blocking signals that you naturally would send to make you ovulate, because we don't want you to ovulate or those eggs. And after we give you the trigger shot before the egg retrieval, we'll bring you in to actually check your levels. And we want to make sure that at that point, the progesterone level is rising, because it means that your eggs are primed, they are maturing, and they are ready for the egg retrieval. So that's how we fit hormone testing and tracking into treatments that we offer as fertility doctors.
Thank you for that. That was really informative and very clear. We did get we got a bunch of questions prior to the event, so I'd love to kind of start digging into some of these. How often should someone check their FSH and AMH levels?
So I think it depends on the situation. So FSH and AMH, what is that, right? Because that's confusing to people. One, you don't want it to be high. The other one, you want it to be high. So FSH, follicle stimulating hormones coming from your pituitary. And if it's high, that generally tells us that your brain is working overtime to get the ovary to do its job. It's sensing that there isn't a lot of estrogen because there aren't a lot of eggs. And so the levels tend to be higher in patients with lower egg counts. Now, I would be very careful about FSH because it is a pulsatile hormone. So I would never just take one level and make a whole life plan or a treatment plan based on that one level. It also is really hard to interpret if you don't test estrogen with FSH, because it's a feedback loop, right? It's not just your pituitary sending out commands to the ovary blindly. It's listening to the ovary. It's sensing how much estrogen is coming from the ovary, and then it's responding to that. If you have a low egg count and there's less estrogen being produced because there's just less machinery to produce it, then yes, your FSH is going to be pushing harder to get the ovary to do its job, right? So but if I only have an FSH level, it's really hard to know exactly what's going on, because with that LH spike that happens mid-cycle to make you ovulate, your FSH actually rises too. So I've had patients in my office who have a random FSH check by their primary care doctor who didn't really understand or know, because this isn't their area of expertise. And they'll come to me crying or really worried or upset that they're in menopause. And I say, look, we don't know anything. We don't have the full picture. Let's retest it with your estrogen level. And let's also do an ultrasound. And lo and behold, they'll have a normal egg count. So it's important to test estrogen with FSH, because if the estrogen is low, if it's like less than 80, maybe even lower than that, like less than 50 picograms per milliliter. I say the units because I think that's important, because different labs may report different numbers because they're using different units. But if the levels are low, your estrogen levels are low and the FSH is high, then that is probably a more reliable indicator of a lower egg count. Your AMH level is easier to interpret because it doesn't vary throughout the cycle. It's not depending on other levels like estrogen. And also, additionally, you can be on birth control and still trust the AMH level for the most part. Women who have been on birth control for 10 to 20 years, it could falsely suppress their ovaries and their AMH levels, but it's still not going to be that drastic of a change usually. Whereas with FSH, when you're giving yourself birth control, you're suppressing your FSH level. And so it's going to give you a false reading. So those are kind of the main differences between FSH and AMH. Now, why do people check it? Because it gives you a spot check or assessment of how many eggs you have at that snapshot in time. And I make that point because it's very limited to this snapshot in time, right? And as I mentioned, we're born with all the eggs we're ever going to have. right? We're born with like 1 to 2 million. By the time you get into menopause, it's like less than 1,000. So by knowing where you're at currently, it can just be helpful, because I can tell you as a fertility doctor, okay, this is kind of average for your age, or below average, or maybe it's high. Now, why does it matter? It actually only really matters if you're going through treatment, because everyone is on a level playing field when it comes to trying to get pregnant naturally on your own without treatment. Most people are going to ovulate 1 egg every month. So it really doesn't matter if you have a ton of eggs recruited at the surface of the ovary, or if you have a fewer number, right? Every month, that recruitment process, I should mention, is like a rationing process. The more eggs you have, the more you pull to the surface and that are available and could be accessed that month. But the less you have, the fewer are available. So that's the only reason we care about it, because things like IVF or egg freezing are capitalizing on the fact that we can access a bunch of eggs that normally wouldn't have been ovulated, but they're available. And guess what? At the end of an ovulation cycle, all those recruited eggs at the surface of the ovary that are available, that we can access, get thrown out. So I get asked a lot of the time about how IVF and treatments might impact someone's egg count. And I tell them it doesn't, because all we're able to get to are the ones that would have been available this month and then thrown out at the end of the cycle. So to get back to the original question, I actually don't think there is a huge amount of value in checking your AMH and your FSH on a monthly basis, because you can't really use that information in a meaningful way. It doesn't tell you anything about the projected change when you're going to go into menopause, when there's going to be a drop off in your egg count. We know that it's not linear. It's not like every year of your life you lose X number of eggs. It tends to be a very subtle drop throughout your early reproductive years. And then for whatever reason, the lower your egg count, or the later, I shouldn't say the lower your egg count, the more advanced your age, you tend to lose eggs faster. And we don't really know why. And so I can't predict from one cycle to the next, or 1 month or 1 year to the next, what that means and how your egg count is going to change. So I think it only makes sense to really test it if you're potentially going to do something about it. If you're thinking about freezing your eggs, it's going to help give you a gauge on how many potential eggs you could get, how your body may respond to the stimulation, and what to expect in terms of egg count. It doesn't tell you anything about your egg quality. It doesn't tell you anything about your chance of a successful pregnancy from a given ovulation. And like I said, 2 women who are the exact same age, so we presume they have the same egg quality, which we know isn't true, but that's all we have to go off of to judge egg quality, is your age, right? So 2 similarly aged women, one with high AMH, high egg count, and one with a low AMH, maybe a high FSH and a low egg count, they have the exact same chance of getting pregnant in my book. Does that answer that question?
I think so. If not, then please feel free to ask follow-up questions in the chat box. Another question we got is, what are the best things I can do to prepare for fertility conversations based on variable cycle times with my OBGYN? For example, LH test, cycle tracking, etc.
So I think the biggest question I have to answer your question is about the variable cycles, right? There can be subtle variability that I think is less important. But if there's major variability and you don't know when your next cycle is coming, I would go to a fertility specialist early on. Or if your OBGYN is comfortable with managing ovulation induction or considering medications to get your cycle to be more regular, then I think it's fine to go to them as well. But the reason I say that is because I think it's really difficult to just use tracking if you have a long or irregular and really unpredictable cycle. It's not wrong to start with that approach, but have a low threshold to seek help, because it not only is it harder and less efficient, but it's not fair, right? Why should you have less tries than the average person who has a standard 28-day cycle? If you're waiting every 40 days or 45 days or 60 days, that means you have one shot, one window of opportunity in that long stretch of time. And it doesn't need to be that way. You should explore early on, I think, options to get a more regular, frequent cycle.
That's a great way to frame that too, because you're right. If you have a longer cycle, you are limiting the number of chances that you have in a given amount of time to conceive.
Right.
You did touch on this a little bit, but maybe you can dive into it a little bit more. What is considered low progesterone in the luteal phase?
I knew I was opening a can of worms when I said that. So the luteal phase is basically the second half of your cycle. Like anything that happens after ovulation, it's like the cycle gets converted to this luteal phase, right? And there used to be this idea that there was such a thing as a luteal phase defect, where it might be this major cause of infertility that some women just have a progesterone deficiency. And now the traditional teaching has really changed and the pendulum has swung in the direction of that probably isn't a true thing. I'm sure there are some cases out there, but it's probably very rare. And the reason why people thought that was that oftentimes when a pregnancy is abnormal or unhealthy, and miscarriage is extremely common, a lot of people don't know this. 1 in 4 pregnancies end in miscarriage. A lot of them may be unrecognized as late or irregular cycles. And it's normal, it's part of our biology. And it's because it's so common that we can ovulate an abnormal egg that doesn't have the right amount of DNA. And if that's into an embryo, it may start to try to implant and then stop growing. A lot of times they're just not going to implant. They just stop growing because if you don't have the right amount of DNA, you don't have the guide for normal growth and development, right? And sometimes, unfortunately, that process gets halted after implantation has taken place. And so there was this relationship that people drew between low progesterone levels and unhealthy pregnancies that didn't continue. And they didn't really have a way to establish cause or effect. There was just this association. And I can really clearly explain why that is. So remember, I talked to you about how when the embryo implants, it makes this pregnancy hormone Hcg, and that's the signal that gets sent to the ovary to say, hey, I'm a pregnancy. Please keep taking care of me and keep churning out progesterone to take care of me. So people would notice, oh, this patient's miscarrying and has an unhealthy pregnancy and the progesterone levels are low. Let's throw more progesterone at the problem and maybe we can salvage it. Now, that direction might be the cause for a very small number of patients, but we have no reason to think that the ovary doesn't know what to do. It knows what to do. A lot of times it's just not getting the proper signal from the embryo because that embryo is not healthy and normal and it has problems sending those signals, right? And so that follicle that's now a progesterone estrogen factory is going to break down because they're not receiving the proper directives from that embryo. Does that make sense? So I don't think that there is, a clear cut point or threshold that we can say, if the estrogen level is less than 10, then this is not a good pregnancy. We know that's not true. I know that's not true because I track women's pregnancies all the time and look at their levels, right? But in general, we know that as a sanity check, you ovulated a week later after ovulation if your progesterone level is above 3. That's the standard cutoff, 3 nanograms per milliliter. What do I like to see if someone has an early implantation, an early pregnancy? It makes me feel good if I see levels above 10. If I see levels below 10 nanograms per milliliter, I tend to supplement because I'm like, what's the downside, right? And it's very difficult to know which pregnancies or people will benefit from supplementation and which pregnancies that isn't the core issue and it's some other underlying issue and it might have to do with the embryo itself that's implanting. But I see minimal harms associated with giving just a low dose supplement. So a lot of us will supplement and we have our thresholds, but that's kind of the guide I use. But it doesn't mean, when I got pregnant naturally, obviously as a reproductive endocrinologist, I was a complete psycho and tracked my own levels. And I had a progesterone of 9 and I didn't start myself on supplementation because I was like, you know what? This is naturally what's happening. And I just watched it. So I really believe that our bodies do work in amazing ways and your body knows what to do. And a lot of times I think a low progesterone level isn't the reason for a pregnancy not happening or being successful. I think it's more a symptom of an underlying issue.
I completely agree. So we actually have a lot of women that are using UVA to monitor the luteal phase. Obviously, that's one of the goals of UVA. But then also, once they believe they've conceived, they want to continue to monitor the progesterone to detect signs of early miscarriage. And like while we're not meant to be used that way, that like we're still measuring progesterone, so it works, right? And our test goes up to 25 nanograms per mil. Like we can monitor progesterone up to that level. So it's been really interesting to see how women's progesterone levels are staying elevated if they conceive, and how high they can go once they ovulate. There really is a pretty broad range. So I understand why you're saying like some women may get the supplement while others may not.
Right.
And we do have many clinicians that are using the UVA data to determine whether to give that supplement or not at specific points in the luteal phase. So that's really interesting. This is kind of a follow-up to that question. What minerals and vitamins play the biggest role in keeping hormones in a good state?
Yeah, I like to keep things simple. I don't think there's any magic pill or vitamin that is going to regulate hormones. It depends what your underlying issue is, right? If you're a healthy individual with regular cycles, I firmly believe that all you really need is a good prenatal that has 400 micrograms of folic acid. And ideally, it's not, always going to be the case, but in a perfect world, everyone would start this 3 months preconception. And it's something that I talk to, all my patients planning to start trying. I do preconception counseling, and that's one major point. And I review lifestyle factors because I don't think it's all about supplements. I think it's about cleaning up your lifestyle and really examining your behaviors and things that you can modify to put your best forward. But there are certain instances where I will talk about specific types of supplements, like women with lower ovarian reserve will sometimes take coenzyme Q10. And they'll take 600 milligrams per day because that's the dose that's been studied, and in some studies it has been shown to boost response to treatment. But I really do like to keep it simple. I think most over-the-counter prenatal vitamins are going to have everything you need. I think there tends to be a lot of focus on this area because we want to gain control and we want to know that we're doing everything that we can to put our best foot forward. But I think that you need to have balance. And I have some patients that come to me and they're just on so many different supplements. And I think there is this tendency to think that it's natural, it's a supplement, it's fine. But I think doing too many things altogether, there is such a thing as too much. And you can have vitamin toxicity. And I think that it's important to just kind of pare it down and keep it simple. But obviously, talk to your doctor. And if you have a specific underlying issue like PCOS or other concerns where you have thyroid dysfunction or other hormones that aren't in balance, there may be a specific role for specific supplements or regimens. But I think for the standard patient who's just thinking, I want to start trying to conceive, a simple prenatal vitamin will suffice.
And if someone says that they have like low estrogen, are there any natural ways that they can increase the estrogen levels?
Well, I think the first question is, why is the estrogen low? If and why are we? What are our goals? If a woman has low estrogen levels because they are hypothalamic, that's a fancy term for whatever reason their pituitary gland is not capable of sending those signals out. Sometimes that can be due to chronic extreme stress. It can be due to an energy deficit of calories or excessive exercise. A lot of times competitive athletes have issues like that. And that can be a real problem, whether you're trying to conceive or not, because you need a certain amount of estrogen in your body to protect your bones and keep them from thinning, and for your heart health, right? So women who have that issue, it's not that they don't have eggs. They oftentimes have a lot of eggs, but they're just not producing estrogen because there's a lack of that signaling coming from the brain. They may have symptoms associated with that. Symptoms of estrogen deficiency include things like hot flashes, but more commonly in that population, vaginal dryness, decreased libido. And then there's women who have a really low egg count and go into menopause early, or they go into menopause at the normal age, which is tends to be around 50. And they tend to have really harsh side effects like hot flashes, and they have all of the same issues associated with low estrogen. So it depends what your goal is. If your goal is to get pregnant, then giving someone estrogen isn't necessarily going to fix the problem. Making them ovulate and have them produce estrogen on their own naturally is going to be the best course of action. I don't think supplements are going to help the underlying problem if the issue is fertility. But if the issue is just quality of life and wanting to protect your bones, again, it depends on the woman's age and what their goals and what their issues are. But in general, giving some form of estrogen is the treatment for an estrogen deficiency. There are other things that you can do, to help with certain symptoms like hot flashes, vaginal dryness, and things like that. But I wouldn't say that there's any vitamin or supplement that we know of that can address those issues head on.
Perfect. This is a little bit broad, but how does PCOS relate to fertility?
So PCOS is, and I'm glad actually this came up because I meant to incorporate it into my biology lesson, but that signaling, right, the coming from the brain, the FSH and the LH, the signals are being sent to the ovary, and then the ovary has to receive the signal in order to actually respond to it and get that follicle to be selected to grow. So when you don't ovulate at all, or when you don't ovulate regularly, it is actually one of two problems, usually. I would say it is a deficiency of the signals coming from the brain, which we just talked about an example, competitive athlete, someone who's extreme dieting or exercising all the time. It's almost like your brain shuts off and says, I'm not going to try to make you ovulate right now because we have an energy deficit and this is not a great time for a pregnancy. And that's kind of the thought process as to why that happens. And then there's I'm sending the signal out, but hello, is anyone listening? Why isn't the ovary doing what I want it to do? And that's PCOS, right? The signals are actually really, really high. Those women tend to have high LH levels. It's not a prerequisite for the diagnosis, but a lot of those women have really high LH levels because your brain is working overtime to get the ovary to listen, and there's some communication blockage. And so that's a really important point when you think about tracking your hormones and trying to hone in on the right to try to have sex prior to ovulation, because women with PCOS can oftentimes have false positive ovulation predictor kits, especially the ones that are only picking up LH, because it's just going to show positive, positive, positive. There's high LH everywhere. There's LH flooding the system. And someone who isn't aware of this pitfall of ovulation predictor kits is going to look at that and say, how could I be ovulating all the time? And I never even get a period. This makes no sense. So women with PCOS tend to come to me very confused if they've been trying to do this at home on their own. They've gone off the pill. They're ready to start. They're tracking and they're wondering what's happening with my cycle because it says I'm about to ovulate every single day. You're not about to ovulate every single day. You're probably never ovulating. And you're just picking up this really high level of LH coming from the brain because it's trying to get through to the ovary.
That makes a lot of sense. We got another question here, which I think could also be related to this. As thyroid hormones are important in general, but certainly in pregnancy, shouldn't these hormones also be monitored? And can a high TSH level cause a miscarriage?
So they are monitored. It's part of our guidelines. And there are mixed thoughts in the guidelines. Actually, there have been mixed results in studies. Yes, some studies show low thyroid function. So the thyroid is a gland, right, in your neck, and it is responsible for everything: carbohydrate metabolism, energy balance. When women have low thyroid function or high thyroid function, the list of symptoms is this long because it affects literally every body system. And its main role, I would say, is metabolism, but it is everywhere in our bodies and important for so many different aspects. It is really important for normal fetal brain development. And the fetus doesn't make its own thyroid hormone, its thyroid gland. is actually not functional until around the 12th week. So that's why we are so crazy about making sure that pregnant women have tightly controlled thyroid function, because we want to ensure there's an abundance of thyroid hormone that can cross the placenta and get to the fetus and promote normal, healthy brain development. And, there have been mixed studies, but there are some studies that show improved IQ scores in women who monitored their thyroid function levels in pregnancy and maintained normal levels. And the goal in pregnancy is much stricter than the goal for a non-pregnant patient who's not trying to conceive, because we know that it's so critical to normal fetal development and brain function. It is tracked, generally speaking. If a patient comes to me pre-conception, I check their TSH level. TSH is coming again from the pituitary, this master gland, and it is thyroid stimulating hormone. And similar to FSH, when TSH is high, it's because it's trying to whip your thyroid gland into submission and get it to work. So a high TSH means your thyroid is actually not functioning at a sufficient level. A really low, abnormally low TSH, it's because your thyroid gland is overactive and hyperfunctioning. And it's actually your brain's way of saying, okay, stop, it's too much. So that's another example of why you can't just measure one thing and look at it in isolation. Well, oftentimes when the level is low, the TSH level, is high, and we're thinking, okay, the thyroid function is going to be low, we'll also check the actual thyroid hormone. We call it T4. And so a lot of times we're testing this pre-conception or in early pregnancy. We know that in pregnancy, the thyroid hormone requirement goes up. And it's not just because we know it's important for fetal development. Obviously, that's one consideration. But in general, you need more thyroid hormone. Women who are taking thyroid hormone and being supplemented because they have a low functioning gland, hypothyroidism, we automatically will reflexively increase their dose of replacement thyroid hormone by about a quarter, because of various changes of pregnancy that just increase the requirement. We know that the hormonal changes can, such as high estrogen levels in pregnancy, can actually lower the amount of the available thyroid hormone because there's more proteins that are binding it. I won't get into the details, but there are several reasons why you need a higher dose of thyroid hormone replacement once you become pregnant. So it is definitely something that we check, and your OBGYN will usually check it at least once a trimester, and maybe even more frequently than that if you're known to have a low functioning thyroid gland.
So I think we have time for one more question. How can we improve the FSH-LH ratio? My LH level is 3 times more than my FSH, at least with my latest blood work.
Right. So I guess the question is that the target that we need to be treating? And what is the problem with having a high LH to FSH ratio, right? Well, women with PCOS tend to have really high LH levels relative to their FSH. People used to use it as a diagnostic criteria loosely. They would say, oh, if it's double the amount your FSH level, then you definitely have PCOS. We now know that that's not a reliable indicator, because some women with PCOS, they meet the criteria based on other points. They'll have a normal LH to FSH ratio. It's not a prerequisite. So I would say to a woman with a high LH to FSH ratio, what are your goals? If your goal is to get pregnant, how frequent are your cycles? Are you getting a cycle? Are you ovulating regularly? If you are ovulating regularly, then I don't really see a major problem with that, right? There is a caveat. PCOS is a very complicated disorder. We could have a whole hour-long discussion on that alone, and maybe we should. But in general, the best way I can describe it is, yes, it's a signaling problem, right? The signals are being sent out, your ovaries are not listening for whatever reason. But we call a lot of different things PCOS. PCOS is an umbrella term that is, your ovaries are playing a game of broken telephone, the signal's being dropped. But it could be different for different people because there's so many different parts of that signaling pathway. And depending on which part is actually impacted, that may explain why no two women with PCOS look exactly alike and have the exact same host of symptoms, right? It's such a mysterious disorder. But we know that there tends to be three things that are interconnected, right? Irregular cycles. We know that women with PCOS, not every single woman, but some may have a tendency towards excess hair growth, acne, oily skin, changes that are associated with androgens or testosterone, male type hormone, right? And there's also this other tendency towards having a strong family history of type 2 diabetes and high blood pressure, maybe having difficulty losing weight, maybe being prone to diabetes themselves later in life or during pregnancy or even when they're younger. So all of these things that are seemingly disconnected are intricately connected. And it's hard to explain why in a short answer, but one of the components that are connected to the LH level is that LH stimulates the production of some of those male type hormones from the ovary. No one talks about this, but your ovary makes testosterone on its own normally. And there's a certain balance, which makes it a friendly, good environment for egg development and ovulation. And LH actually drives production of testosterone from the ovary. So it could be a problem, outside of whether you're ovulating normally or not. It could be a problem if you have really, really high LH levels, because maybe that's tied into having higher testosterone levels and having some of the bothersome side effects of that, and having an imbalance of testosterone and the other hormones that are produced by the ovary. And the problem with testosterone is it gets converted into estrogen very rapidly. And if you have really high testosterone and estrogen levels being produced, that tells your brain to stop churning out signals. And that's part of the reason why women with PCOS have irregular cycles. It messes up that feedback loop, and there isn't a normal signaling system as it should be. And so, I would say don't treat the level, but ask what are your symptoms and what are your goals. Someone with a really high LH who's having acne, unwanted hair growth, yeah, that's probably a driving force. And how do we rectify that? Well, if you're not trying to get pregnant, one of the easier solutions is going on birth control, because it helps to kind of really tamper that and lower that. And also it's going to help bind some of the free testosterone from your blood. So I think, if your goals are quality of life issues and improving those versus pregnancy, that's going to dictate how you manage an imbalance between LH and FSH.
Thank you for that. That was such a comprehensive answer. And I know that's a really complicated question that we just tried to answer too about PCOS. I think we're going to hold you to hosting another event focused on PCOS for our community. But Dr. Lucky, thank you so much for your time and for taking the time to answer all these questions so thoroughly. I don't think I've ever had a speaker explain the entire reproductive system in such layman's terms that anybody could honestly understand and pick up. So I hope everybody's walking away with that knowledge. And
I thought you were going to say I've never had a speaker do so much crazy sign language.
Well, actually what it showed me is that you can basically create all of the female reproductive systems for him.
With my body.
Yeah.
Like a clear whiteboard in front of me.
Exactly. But thank you so much. We are going to be sharing this recording with everyone that's in attendance and on our YouTube channel, as well as our social media. If you have any questions, Dr. Lucky, is it okay if we share your social and contact information?
Yes, I would love that.
Great. So we will do that. We'll also share a link to your blog, The Lucky Egg, which I think is an amazing title.
And also,
but thank you. Oh, go ahead.
York. So if any of you, want to learn more, and if you need to see a fertility specialist, I'm here for you. You can call the office and make an appointment.
Great, thank you. Yeah, Dr. Lucky works at the RMA of New York. I've been there before. It's a fantastic facility. Thank you so much for your time. And just as a reminder, we do have a National Fertility Awareness Week sale going on for the remainder of this week. 20% off of your purchase. Just use the code NIAW20 at checkout. But thank you guys so much. I appreciate you spending your Tuesday with us. And thanks, Dr. Lucky.
You're so welcome. Thank you for having me.